All right, time for our next speaker, Kate Reid, who is a nurse practitioner from the Australian Nursing Midwifery Federation. So Kate is a palliative care nurse practitioner at Canberra Health Services. She's working to meet patient, carer and community needs by the provision of flexible, equitable models of care within appropriate service delivery frameworks and policy development. Working with the health service, Kate provides a clinical point of care focus on the current issues and strategic development and implementation. Please welcome Kate. Her presentation is Medicinal Cannabis in Palliative Care, Discussion and Case Stories.
Hello. So my name's Kate Reid. I'm a palliative care nurse practitioner. I'm not with the ANMF, I'm sorry. I am a member, but I'm not with them. I'm here as part of Canberra Health Services, and also in my previous role, and I just move this along, I was part of the Australian Advisory Council on Medicinal Cannabis as well, which was while I was with Palliative Care Australia. And I'm hoping to talk to you today really about not just about medicinal cannabis and its bit of background in palliative care, but also illustrate a few case studies of a few patients that I've been caring for. So medicinal cannabis, as we've covered a little bit of today, is we've got three different types really. Is the phytocannabinoids that are derived from the cannabis sativa plant. And of those, there's over about 500 natural products for which more than 100 are classed in cannabinoids. Then we've got the ratio of THC, sorry. It's very hard when you work in a place that's called TCH. So THC and CBD differs depending on the plants. Then we've got the endocannabinoids, which I also did not learn about at all when I did my, my undergraduate or my postgraduate studies. So they're naturally occurring cannabinoids in the body. Then we've got the synthetic cannabinoids. It's an awful word that are made in the laboratory for medicinal cannabis. So that's the endocannabinoid system. We're looking at it as a very complex neuromodulatory system that was discovered in the mid-1990s. So this was really quite recent as well. The receptors of the CB1 are primarily in the central nervous system, and CB2 are primarily in the peripheral nervous system and the immune system, with the three main ligands that you can see there. It's pivotal to memory, mood, appetite and pain. They're known effects of exogenous cannabinoids are actually what's informed a lot of the information around what happens with the endocannabinoid system. So how are cannabinoids metabolised? Because it's really important when we're looking at how we're going to be prescribing and for who we're going to be prescribing for. So the metabolism occurs mainly in the liver. It involves a CYP450 pathway, and THC does accumulate in the fatty tissues. It's excreted in both faeces and urine, and it does have quite a long half-life, so it can be up to 5 days for 90% to be excreted. So the current use is really, there's a lot of growing interest, obviously, around and study and use. So there's a lot of different things happening with medicinal cannabis. There's a strong push for wider access for medicinal cannabis from consumers, from advocacy groups, media and programs and stuff that's happening overseas as well. So it's been used quite widely in epilepsy, MS, nausea and vomiting due to chemotherapy, and nausea and vomiting due to HIV/AIDS. This is across the world. And also various pain syndromes and symptoms due to palliative diagnosis and or treatment, which we're going to talk about in more detail. But what we can actually provide a prescription for medicinal cannabis is what's approved by the TGA. So that's chemotherapy-induced nausea and vomiting, refractory paediatric epilepsy, palliative care indications, cancer pain, neuropathic pain, spasticity from neurological conditions, and also anorexia and wasting associated with chronic illness, which we'll often find in cancer as well. So there's a lot of talk about safety and tolerability and how well medicinal cannabis is tolerated, and it certainly is. Studies have shown that the adverse effects are very similar to that of a placebo. It does appear to be well tolerated, particularly after the first few days, and so usually if there's going to be a little bit of disquieting symptoms, they will often pass. The current evidence shows that in excess of 30 milligrams a day of THC, then the risk of adverse effects does then climb. And as you'll see, palliative care, we use quite low doses. So contraindications that we're working with is anyone is, of course, a hypersensitivity to medicinal cannabis, pregnancy, and also relative contraindications are mental health disorders such as substance abuse or psychosis. Remember, these are all the guidances that are coming from the TGA as well. Seizures, because even though we're using them to treat seizures, there's believed to be an increase in THC-rich products, which I think we touched on before, what Lisa was saying. Then severe cardiac disorders. So dosaging, well, it's kind of anyone's guess. Sometimes it feels a little bit like that. So it can be quite confusing depending on what you read. So always start low, go slow, and titrate to effect. The duration of a trial, I would never trial more than 4 weeks. If in 4 weeks it's not working or hasn't achieved what you were working with your patient to achieve, then there's probably no point continuing. I start at 0.3 mils, 2.5 milligrams on Nocte for 2 nights, and then I'll increase it to BD in consultation with the patient. That's only if it's obviously well tolerated. I always use lower doses in the elderly and in the frail, and I do a 2-weekly second week review when I first start, though usually I'm calling them a couple of days after I start as well, but a face-to-face 2-weekly review and a 4-weekly review. And I will make sure that the patients understand that this is what they will be doing if I am going to be prescribing medicinal cannabis for them. This is the follow-up plan that we will be sticking to. There was a really good study by Portenay that showed that there was quite low to moderate dosing was found to be safe and effective, and that was in opioid refractive pain. So cost is an ongoing issue. Palliative care patients, because they're not using quite as much of it as, let's say, the epilepsy population, it's probably up to around about $200 a month. But these are remembering that palliative care patients do have a lot of financial issues, usually by the time they come to palliative care, and they've got a lot of financial distress and strain. So on top of everything else, this can be undoable for a lot of people. The higher the CBD concentration, usually the higher the price of the product. And manufacturers are usually very kind and will provide us with a compassionate bottle for the first prescription. So I just want to take us back a little bit to what palliative care actually is, where we come from. So palliative care itself is an overarching approach to the support of a person who has life-limiting illness. It is across all settings of care. You will see palliative care patients in every single setting, not just in hospitals, not just in the community, everywhere, in jails, doesn't matter where they are, the setting of care doesn't matter. And all people who are healthcare providers will provide palliative care in some form, in some way. Where it becomes a medical specialty is, like myself, I'm a specialist palliative care nurse practitioner, which means I deliver specialist palliative care. This is a multidisciplinary healthcare service where our substantive work involves consultative and ongoing care and support for people with life-limiting illnesses. So palliative care and cannabinoids, there has been a little bit of work in this area. It's definitely a growing field. They are limited in the studies, but that's not uncommon in palliative care. There's quite a few things that we do in palliative care that rely a lot on anecdotal evidence and also case management, case studies, as well as the evidence-based nursing or evidence-based medicine as well. So the TGA guidelines from 2017, which you can easily access on their website, say that there's a low evidence in all aspects, but recommend consideration in refractory symptom management, which is a lot of my patients with refractory symptom management. There's a really good study by Muki that did not find that there was a statistical significant benefit for palliative patients with cancer, but did see a trend in improvements in cancer pain reduction, but low quality evidence. And they found some improvements in appetite, nausea, weight gain, HIV and Parkinson's disease. This study's not been repeated. It'd be really good if it actually has some very good indicators for being repeated. But what really turned the tide for us in 2018 was this pivotal study that was published at that point. There was 2,970 patients with cancer, and they had timestamps done at 6 months, 1 month, 6 months, 1 year, and 2 years. And at the 6-month interval, they found that there was 96% reported a symptom improvement, and that the quality of life had improved significantly in those patients. What is also very interesting is how many patients reduced their medication burden, with the overall being 35.1%, and with opioids, they had a reduction, and few also ceased, quite a few also ceased opioids altogether. So what makes palliative care different when it comes to medicinal cannabis prescribing? Well, there's multiple different disease modalities, both malignant and non-malignant, that we see as specialist palliative care. There are multiple and cascading symptoms experienced. So people will come to me with 3, 4, 5 symptoms that are affecting their quality of life significantly. Targeted therapies and palliative treatments do cause side effects, particularly in people who have gone through lots of lines of therapy, and they will also be getting a lot more side effects from those therapies, because as we go down the line, they just have more side effects. So quality of life and reducing suffering is the priority of what the care I deliver. There is a high patient bias as well for patients in the palliative care community. So it's a very strange thing where I will get referrals from doctors who will say, can you see this patient because they want medicinal cannabis? I have never had a referral that says, Kate, can you see this patient because they want morphine? Dictating what I'm going to be doing for that person, I would love to be able to write back and say, that's great, how about you do it? But since you've decided that's what they should have. But it's a really interesting change in the referral process that they think that they're going to do it, but we'll just pass it off to you as the specialist palliative care, which is great in a way because at least we get to see the patients. So when do we use cannabinoids in palliative care? Well, we do it a lot when standard pain and symptom management has failed. So sometimes we talk about this with a lot of medications where we worry that because we are giving it at the point of failure, then what are we seeing as the outcomes for patients? Are they truly good outcomes that we can actually hang our hat on and say we started it in the right time? Also to augment current symptom management plans, particularly in relation to pain and or nausea, and also to work with the patient and their goals of management. If someone comes to me and they really want medicinal cannabis, then I will work with them to make sure that they can get it. But that we do have to go through a few things first. So I want to be able to talk to you about a couple of case studies if I've got time. I'm not quite sure if I'll run over. So we'll see how we go. And please, if anyone wants to ask any questions, it's a big room with not that many people, so please interrupt me. I'm happy to take questions. So this is John. He's a 21-year-old male who's living with a life-limiting illness of a slow-growing cancer, very slow-growing cancer. It's a history of multiple endocrine neoplasies, the type 2, and also CCF and chronic end-stage kidney disease. He was referred to specialist palliative care for pain, nausea, and appetite. Very tall young man, very, very thin, was a bit of a gamer, and so he was very, very pale. Had significant side effects with all the first and second line opioids that he'd been given by his GP and his specialists, and he was still under a paediatrician at that point who were passing him over to the adult healthcare world. So his parents had started medicinal cannabis, CBD only, and felt it was helping with his symptoms. And they were asking for a sustainable, consistent and legitimate supply. They were getting it from, I believe it was the US at the time, and it was often getting interrupted in the post, or the company would go bust and they would have to find a new supplier. And so that was really getting very difficult. And his mother was quite high up in the public service, and she was really concerned that she was going to get in a fair bit of trouble. So this was back in 2017, and no nurse practitioners at that point in Australia had prescribed medicinal cannabis. I started this journey back then. It was a very interesting one. So I was the first one to prescribe it at that point. I sought a lot of advice from other experts who had been involved in medicinal cannabis already. And I then decided upon a formulation of CBD 20:1. And I did this in talking with the medical team that I work with as well, because they hadn't actually prescribed it either. So we kind of all did this together, but I was, obviously he was my patient, I was leading the care. So we felt that was going to best mimic his supply that he had, or we thought that he had. We weren't 100% sure what he had. So it took 4 weeks at that point, which wasn't too bad considering I've just heard 16 months. So what I had to do first of all was find which one was I going to get from and that was on the Office of Drug Control website. So I went with Health House at that time. The TGA SAS Category B approval was done. That took a bit of work. The ACT Health, then I had to get their approval as well. And then I had to find a pharmacy that was willing to have it come into that pharmacy. And then I had to make sure that my hospital, my area health care was happy with me prescribing it as well. So the outcome is that the patient, John, received and started on 0.5 mils of medicinal cannabis, the 2021 BD. I did a presentation to my colleagues the day after, and it was standing room only. That was how big the interest was at the time. There was a concern raised by a member of that who I presented to that medicinal cannabis actually wasn't on the hospital formulary. That wasn't mentioned at all through any of the process beforehand, and that became a massive issue, and it involved in ending up having lots of meetings and lots of distress around that. So I had to pass the prescribing on at that point to the medical director, and he didn't get in trouble. It was very strange considering we worked for the same company. So it was an interesting take on what was happening at that time, but that was 2017. Thankfully, things have improved. But for John, he was able to stop his slow release opioids, and because he felt that they were causing him a lot more nausea, and his appetite was a huge problem for him. He felt that that little bit of THC that we probably wasn't getting before was helping with the nausea, and I did quality of life indicators. Those are the tool that I used to measure how he was going, and occasionally we did that by email as well, because I was over follow-upping. I was following up every week, and I was making him send me it on email. So he's continuing to do well on medicinal cannabis, and he's on the same dose 5 years later. He was able to go overseas, and he has participated in camp quality activities, which was one of his main things that he wanted to be able to do. He still remains under the care of specialist palliative care because no one else will take over the prescribing. He doesn't need specialist palliative care, to be completely honest, in his primary palliative care. But so that's John's story. So I'll introduce you to Jack. So Jack I saw back in December in 2019. He was a 42-year-old man. His main carer is his mum and his partner who didn't live with him at the time. So Jack had had a pretty rough time of it. He had multiple myeloma. It was diagnosed earlier on that year, and he had multi-level lytic disease and pathological fractures, including an L1 compression fracture that had retropulsion. So he'd had a single fraction of radiation to that area. But he'd also had a autogenous stem cell transplant, and he had stage 5 kidney disease and was on hemodialysis 3 times a week. So when I first saw Jack, he was in lots of pain. He was in a wheelchair because of the pain. He couldn't walk. Quite a tall, fit-looking guy, and he found that his pain in his lumbar spine was about a 7 out of 10 with movement. He had midline tenderness at L2 and with allodynia. And he had no sensory changes, but his bony pain increased every time he had his denosumab injection every month, which is not uncommon. He had nausea, which is secondary to treatment, and it was caused him reduced intake, and he's having some relief metoclopramide, but not really much relief. His quality of life, he just felt awful. He felt like his whole life had changed due to the diagnosis, and he was in agony all the time, and also that he was having to come into the hospital constantly, and that was just adding to the burden. So he had also just started an audio-visual business and was having some success when all of this happened. He moved back in with his mother, which was a bit tough for him at 42 years of age, and he found that the side effects to analgesics that he had tried, which included codeine, oxycodone, fentanyl, pregabalin, and had all been intolerable for him, and he completely lost faith in traditional medications. He was really anti-opioids and adjuncts. He was wanting to explore medicinal cannabis for pain management. So I had what I do with all my patients, I talk about what the goal of therapy would be, and we were talking about how it would looking at increasing his quality of life, and that we'd be measuring those indicators, and we'd do that through pain and nausea management. We also questioned about how the therapy would be impacted by hemodialysis. I had no idea. There was not a study I could find that would tell me anything about whether or not it was going to be dialyzed out or not. And so we were really just crossing our fingers and hoping. And there was a risk of significant enzyme inhibition because due to this history of other medications, other side effects that he had, that pathway is not dissimilar. So I was quite cautious at that point too. So we talked about all this. He knew the risks. He knew it was an unapproved substance. He knew he had to come see me a lot over the next, while I was going to be prescribing it. So we started a low dose CBD THC of 1010 and started at 0.3 mils noctate and 4 weekly follow-ups from then on. So skipping forward to now. So Jack has struggled a lot with his neuropathic pain. That was just the thalidomide treatment, really. He's got new pathological fractures in 2020 at T12, L3 and L4, and he's got ongoing complications with the fistula they put in for hemodialysis. So he's now managed on CBD 1010 and 1 mil that he has in the morning and 1 at lunchtime, and he has a CBD more rich substance at night. He also has some paracetamol every now and again, and I've managed to convince him that when he has these pain episodes to use a bit of methadone, and he will also use some hydromorphone if need be. he doesn't increase his CBD too much. He probably does it quite happily on his own, but he probably doesn't tell me about it because he's under strict instructions to stick to the prescribing pathway that we're under. So the perception of needing to remain on complementary medications for him has led to him having pain when he shouldn't have had pain. He's so fixated on remaining only on medicinal cannabis that he will suffer beyond that, and that can be quite frustrating as a clinician. But we're able to have very open conversations about it. And during COVID, when he couldn't come in, we still continued to have 4 weekly catch-ups, which are now really about 8 weekly because he'll contact me if there's a problem. So Jack's quality of life, he's rarely uses his wheelchair. His AV business is now going really quite well, helped by COVID. And he's got a modified social life, but it's working. And he comes to see us all the time. I have got one more, but 5 minutes, okay, I can't whip through it. So this is Trent. He had an urgent referral to me in 2020. I gave phone advice at that point, and he had a Merkel cell tumour in 2002 of his nose, and he had extensive surgery. He'd had recurrence, more radiation, more surgery, another recurrence, more radiation. So he had severe multimodal pain, loads of opioid issues. I rotated him when I first met him, and I increased his neuropathic management. And we supplemented. He was supplementing his analgesia with his own cannabis, but he couldn't afford it. He was really concerned about the cost. He lived with his uncle, and he had shared custody of his son, who had a good parenting relationship with his ex-wife. He loved his motorbikes. He'd had a fun life. He could read him with his tats. So he wanted to look at getting medicinal cannabis because he didn't want to source it illegally anymore. He was worried about the custody of his son. So at the next appointment, once there was acceptable levels, and this is really important to know, I don't know what those acceptable levels are, but there is a level of where I'm happy before I start talking about medicinal cannabis or being accepting of it, because you do have to go through certain lines of therapy. And when you go through a TGA, SAS application, you need to prove that you've tried different lines of therapy. And so he was already on that combination there, and he stayed on that management for then another 6 months before he started to deteriorate. I ended up passing over his care to the home-based palliative care team because we needed a syringe driver, and he lived across the border, and then the medical officer for palliative care just took over my prescribing. So there's just some take-home learnings from that very quick little last ones. It's really, for palliative care patients, and I'm assuming for a lot of the patients that we see, it is a really important part of the symptom tool management that we can use. It's not the be-all and end-all, but it's a really important part of the tool bag that we have. We are there to reduce suffering. We are trying very hard with what we're given, and this is one of the things that we can use with the prescribing pathways that we can use. So it has a significant positive bias. If people want it, it will obviously, and they get it, it will work to some degree. But so it's very important to monitor constantly to see if there's any side effects. It requires stronger, consistent uptake by primary health care. It can't be just left to the specialists. GPs need to be doing it too. It is exhausting work, and I'd like to be able to pass over those people to their primary healthcare providers. So there's also approval pathways need to be consistent and equitable for nurse practitioners. If you look at the TGA website, they will still only talk about medical practitioners. That is not the case. It is nurse practitioners as well. And so I'm always getting asked, can nurse practitioners prescribe? Absolutely they can on a federal level, but at a state level, it is still incredibly inconsistent. The ACT, I've got great relationships there, and we've built a really good pathway. So it's working very well, and I've been heavily involved with the TGA, but it's nowhere near the consistency it requires, and patients shouldn't be prescribed it based on their postcode. Good patient outcomes, I find it really helpful when it's mixed modal pain, particularly in head and neck patients or GBMs, and also where people have got opioid refractory pain and multiple myeloma, those types of really complex long-term pain management plans that we can use it for. But I would like to ask you all to make sure that you are speaking to your health, area healths, and getting things moving better for consistency across the federations, because it really is an unfair system that we're working with at the moment for our patients.